Standard Occlusion Theory for TMD. I am Sotokawa, a dentist practicing in Morioka City, Japan. This theme covers the occlusion theory essential for treating temporomandibular joint disorders, organized into the following 24 topics. This time, I will explain the 15th topic. Theory of vertical dimension. 15. Theory of vertical dimension. Contents. 1. Discussion on occlusal vertical dimension. 2. Aukeson's explanation. 3. Dawson's counterargument. 4. Questions and answers regarding occlusal vertical dimension. 5. Dawson's theory. 6. Principles for determining occlusal vertical dimension in patients with dentition. Summary. 1. Discussion on occlusal vertical dimension. The theory of occlusal vertical dimension remains a subject of debate among many researchers today and is one of the challenges in occlusal theory requiring a unified perspective. While there is little difference in the interpretation of terminology related to occlusal vertical dimension among researchers, there are considerable differences in how it is addressed clinically. Below are explanations of occlusal vertical dimension from various specialized texts. 2. Aukeson's explanation. The occlusal vertical dimension represents the distance between the upper and lower dental arches during occlusion and is affected by tooth loss, caries, tooth movement, and wear of the occlusal surfaces. A common condition leading to loss of occlusal vertical dimension occurs when multiple molars are lost and the anterior teeth become the functional stop during closure. Since maxillary anterior teeth are not positioned to accept strong occlusal forces, as they incline labially and the occlusal vertical dimension decreases, a gap develops between the anterior teeth. This is called molar occlusal collapse and is associated with functional impairment. Occasionally, the occlusal vertical dimension increases due to the placement of restorations that are medically excessive in height. Any alteration of the occlusal vertical dimension, whether an increase or decrease, requires careful consideration. 3. Dawson's counterargument. Dawson identifies 4 significant errors in the conventional concept of occlusal vertical dimension. A. Occlusal vertical dimension cannot be determined based solely on the patient's subjective comfort or discomfort. B. Utilizing the resting space to determine the appropriate occlusal vertical dimension cannot be considered an accurate procedure. C. Determining the mandibular resting position is not a key point in determining the occlusal vertical dimension. D. A reduction in occlusal vertical dimension is not a cause of temporomandibular joint disorders. Each point will be explained below. 3. Dawson's counterargument. A. Occlusal vertical dimension cannot be determined based solely on the patient's subjective comfort or discomfort. Reason. By wearing an occlusal splint, the bite height can be increased without causing discomfort to the patient. Conversely, removing the occlusal splint allows the bite height to return to its original state, enabling occlusal adjustments. Patients possess the ability to adapt without discomfort even when bite height undergoes significant changes. Therefore, the patient's perception of comfort or discomfort is not an appropriate criterion for determining bite height. B. Utilizing the resting space to determine the appropriate occlusal vertical dimension cannot be considered an accurate procedure. Reason. Patients readily adapt to changes in occlusal vertical dimension and quickly establish a new resting space. The amount of resting space varies significantly between patients, and even within the same patient. Considerable variation occurs depending on the time of measurement. C. Determining the mandibular resting position is not a key point in determining the occlusal vertical dimension. Reason: the so-called neuromuscular dentistry, which is gaining popularity recently, has one major problem. It applies the mandibular resting position obtained through artificial stimulation as the standard for occlusal relationships. This method ultimately results in unnecessary occlusal elevation, causing a significant amount of overtreatment. The mandibular resting position, which serves as the measurement standard for the open bite space, exhibits considerable variability. Therefore, regardless of the measurement method employed, establishing a procedure to determine an appropriate occlusal vertical dimension using the mandibular resting position as the benchmark for the occlusal relationship is difficult. D. A reduction in occlusal vertical dimension is not a cause of temporomandibular joint disorders. Reason: the concept that temporomandibular joint disorder arises from a decrease in vertical dimension of occlusion is widely believed by many dentists and has become deeply ingrained. However, it is actually a misconception. To understand why this idea is incorrect, it is necessary to accurately grasp the anatomical structure and biomechanics of the temporomandibular joint. Due to the misunderstanding that the mandibular condyle moves up and down with changes in vertical dimension of occlusion, erroneous treatment methods attempting to reduce joint load through occlusal elevation have come to be implemented. 4. Questions and answers regarding occlusal vertical dimension. Reader's question: if changes in occlusal vertical dimension are neither the cause of discomfort nor the cause of temporomandibular joint disorder, then shouldn't we stop discussing occlusal vertical dimension altogether? Dawson's response: inadequate understanding of the physiology and biomechanics of the vertical dimension of occlusion has led to inappropriate overtreatment, resulting in medical malpractice in dentistry and misdiagnosis of TMJ disorders. Since comprehension of the fundamental nature of the vertical dimension of occlusion significantly impacts the diagnostic capabilities all dentists must acquire, we must deepen our understanding of this concept. 5. Dawson's theory. A. Fundamental concept regarding occlusal vertical dimension. The most crucial point in understanding occlusal vertical dimension is that, as shown in the illustration above, the length of the closing muscles A during repetitive contraction determines the occlusal vertical dimension. The upper and lower teeth themselves do not determine the occlusal vertical dimension. That is, as shown in the illustration below, the space between the upper and lower jaws is determined by the length of the closing muscles A. The teeth of the upper and lower jaws, by contacting within this space, undergo extrusion or intrusion. Consequently, the length of the closing muscles during repetitive contraction establishes the space between the upper and lower jaws and determines the occlusal vertical dimension. B. Causes of occlusal vertical dimension. Occlusal vertical dimension is established during childhood, beginning when the teeth of the upper and lower jaws start erupting, continuing as they routinely contact their opposing teeth, and concluding when tooth eruption ceases. The positional relationship between the upper and lower jaws where these teeth contact is controlled by the closing muscles. Even after reaching adulthood and the occlusal vertical dimension is complete, it remains controlled by the closing muscles. Therefore, even if the occlusal surfaces of teeth are added to or reduced, after a certain period of time, extrusion, intrusion, or reabsorption of the teeth within the alveolar bone occurs, and the occlusal vertical dimension returns to its original state. That is, the rate of tooth extrusion or intrusion is faster than the time required for the closing muscles to adapt to a new occlusal vertical dimension. C. Reasons why treatment involving occlusal elevation is rejected. After occlusal elevation, within 6 months to a year, only detrimental adaptive reactions remain. As indicated by the blue arrow in the right illustration, teeth may be pressed down and embedded within the alveolar bone, teeth may become worn due to bruxism, or teeth may become mobile due to reduced resistance of the periodontal tissues. D. Elevation of occlusion for temporomandibular joint disorders. Elevation of occlusion can sometimes eliminate discomfort in patients with temporomandibular joint disorders. However, even after elevating the occlusion, teeth with added occlusal surfaces will be pressed down and embedded into the alveolar bone, and the elevated occlusal vertical dimension will return to its original height over time. Therefore, if the goal of treatment is occlusal stability, it is logical to establish an appropriate occlusal vertical dimension from the outset. E. Unloading at the TMJ. Elevating the occlusion does not reduce the load on the temporomandibular joint. The increase in occlusal vertical dimension is caused by rotation of the mandible with the mandibular condyle as the axis. That is, even when separating the upper and lower dentition using an occlusal elevation appliance, the mandible rotates while the mandibular condyle remains loaded. The mandibular condyle does not move vertically away from the condylar head. F. Restoration of lost occlusal vertical dimension. Even when teeth undergo attrition, they correspondingly erupt forward, so attrition does not reduce the occlusal vertical dimension. Restoring the occlusal vertical dimension by replacing the tooth structure lost to attrition results in an open bite. 6. Principles for determining occlusal vertical dimension in patients with dentition. A. The vertical dimension of occlusion should be selected to achieve both aesthetic and functional satisfaction through minimal dental treatment. Excessive dental procedures aimed at elevating the occlusion to a height believed to be optimal should be strictly avoided. B. The cusp-to-cusp contact position in the molar region determines the current occlusal vertical dimension. This vertical dimension harmonizes with the intermaxillary relationship established by the length of the closing muscles during repeated contraction. C. The occlusal vertical dimension determined by the muscles can be measured by assessing the distance between the origin and insertion of the closing muscles. Regarding the distance between the origin and insertion of the masseter muscle, clinically, the best method is to measure between the zygomatic bone and the mandibular angle. D. When measuring the vertical dimension of occlusion, it is essential to consider the position of the mandibular condyle during maximum intercuspal position. This is because changes in the vertical position of the mandibular condyle during maximum intercuspal position affect muscle length. E. When it becomes necessary to alter the vertical dimension of occlusion, the occlusal contact pattern in the anterior region should be used as the reference, not that in the molar region. That is, if occlusal interference in the molar region at centric relation prevents occlusal contact in the anterior region, and occlusal adjustment is selected as the optimal treatment, the molar region should be reduced until anterior teeth make contact at centric relation. Increasing or decreasing the occlusal vertical dimension is entirely tolerable for the patient. If occlusal contact is present across the entire dentition during maximum intercuspal position and the mandibular condyle maintains its centric relation, it is only natural that altering the occlusal vertical dimension will cause no harm to the teeth or periodontal tissues. Even if one attempts to alter the proper occlusal vertical dimension, the modified height cannot be permanently maintained. This is because it reverts to the so-called inherent occlusal vertical dimension measured by the masseter muscle region. Since the height achieved through occlusal elevation is not sustained, unnecessary occlusal elevation should not be performed. Summary: the existing occlusal vertical dimension should be altered as little as possible. If changing the occlusal vertical dimension is necessary, the least invasive dental treatment method should be selected to achieve the best possible aesthetic and functional results. Dental treatments performed by altering the occlusal vertical dimension often lead to unsatisfactory outcomes. Therefore, dentists must have a correct understanding of the occlusal vertical dimension. Standard occlusion theory for TMD. 15. Theory of vertical dimension is now complete. If you enjoyed this topic, please click the like button. If you have any questions or concerns, please write them in the public comment section below. The next topic is the 16. Smile design.